All right, welcome back. We're moving forward. So let me get our slideshow started. We're on chapter 11. So now we're getting into the gynecological healthcare for lesbian, bisexual, and queer women and transgender and non-binary individuals. So here's some statistics. I'm not going to go over that with you guys. I want you to be able to look over some of the stuff so you can see what the statistics are. So just some terminology that I think everybody needs to identify with. Would you not agree?
Absolutely.
Need to
And
agree.
There's a lot of new terms that somebody who's been in it a long time now that I'm having to get familiar with.
Absolutely. And so I will let you guys read through these. I'm not going to bore you. You guys can read lots and lots of terms. So, and what do we take away with this as APPs is essentially discussing this with your patients. You know, do you have a rapport with your patients? You know, have they told you how they identify? You know, I think Terry and I were kind of discussing that. You know, is it part of the social history? Is it part of the questionnaires that gets answered even before the patient comes in? Like you said online.
Yeah, so some of our questions are done online, kind of a the pre-form, I can't remember what they call it, but those that are open to do that, they will do that online, and that is on the social history. I do request that my assistant does go over this. Are you sexually active, and what relationship are you in?
Is it monogamous?
Is it monogamous? Is it are they with a heterosexual or a homosexual relationship? And sometimes that's very sticky for her to do, but it's very important on my end that whenever I do, and if she don't, I have to, but you know, it's very important that if I have somebody that is in a homosexual relationship, I need to be able to address her needs at that point. And of course, I don't see them, but we need to be able to address those needs regardless of what they identify as with.
Absolutely, absolutely. And I think it's important for that rapport with that patient so you can, you know, help them as much as you can, you know. So definitions, once again, when it talks about sexual orientation versus gender identity, they're talking about two different concepts. So sex and gender, two different concepts. So you have to understand what that looks like. So sexual orientation, which means who are you attracted to? How do you identify? What kind of behaviors do you have? Whereas gender identity is more like your natal sex, like, you know, how you were born, how you identified, and your expression. So transgender, so y'all can look at that umbrella term, so to speak, describes person's whole gender, identifies difference from sex or what you were assigned to at birth. So that's transgender. There's gender affirmation, and cisgender is someone whose gender identity matches their natal sex. Okay. Complexities of identity and behavior. So don't forget that their identity doesn't always mirror what their behavior may be. And there could be some fluidity there, you know. Always base your assessment, and I know you would agree with this, and care plan on their behavior, their current anatomy, and the patient's goals, right? Because I've taken care of a transgender patient actually in clinical in the past, and I totally had to base my assessment on what the patient, how their natal sex, so to speak, and really coddle that experience for the patient. Okay, so you have to understand that, you know, we have to know what parts that they have and how to treat these patients appropriately, so to speak.
I've had a lady who explains to me that she doesn't identify with a part of her body and that she wants it changed. And I had to be honest with her. Our rapport has been for the past few years. So she has really made strides in expressing her being more open as time goes by. So we've got a good rapport, and she feels like that she can be honest with me. And when she was making a comment that she didn't identify with her breasts, then I told her, I said, help me understand. I'm willing to help you. But she had already found a surgeon to do her surgery. But she spoke to me with what she hoped that I could help her with. So, and I don't really specifically remember what she asked me to do, but I was able to help her at that point. And I can't remember, but yeah, from time to time you may not have a clue, because she had been married before, and she was a young woman, but it's obvious that she's changing parts of her identity. So
yeah. Right. So remember, you always have to remember, and I would say, have empathy towards these patients and understand where they're coming from, because they do experience interpersonal and institutional discrimination to some degree. And so we really need to, and also like a HIPAA violation to that matter, we have to be careful. Even I know you even have a situation where you had to be careful because was it that same patient
who we had an employee, and she knew this employee, and I had to reassure her, because this employee only did she was a support staff. So I made her aware. I said, all that she would be able to see is that you're coming in to see me. She cannot see the record, even as another employee. She could not see that record. She could not see anything that I was doing to her. And if that person did open up, there's people in our institution that follow that,
Right.
and
Right.
they will
shut it down.
Yes, exactly.
Yeah, they come get you.
Yeah. So
Yeah.
we don't look at anybody else. Say, if I know somebody else in my practice that's maybe on a personal relationship, I do not pull that record up, because I don't want that is a
Absolutely.
big violation.
Absolutely.
But anyway, that was the problem that we had. And so I was able to say, there's no way that she can do that.
Right. So you can see how that could cause some sort of, stress for that patient themselves, because they want their business to be their business. And so we need to all understand that as well. Still kind of talking about minority stress. It differs from daily stress. And you guys can read that. May even cause negative physical and emotional impact. So it can, impact them emotionally. There's historical trauma that you guys can read about. Then we go into what's our responsibility as clinicians. And of course, we're responsible for culturally responsive care, right? Exactly. You have to understand that the healthcare needs and concerns of this population group, and you have to create that environment for them, and a trusting, working relationship, of course, to all people, no matter what their gender is or identity, how they want to be sexually oriented, whatever the case may be. And there's some resources in your book that we're going to refer you guys to, the boxes 11-1.
And I would just encourage you just to learn what you can. More and more journals are, you'll see more research, and to explain to those of us that are like, I did not learn this whenever I was in practitioner school, that I mean, they touched on it, but I'm having to learn outside of being taught this. But there's more and more research articles that you can read to become aware of this. But so in my case, but
I've got a colleague that actually sent me to a website that actually you can do CE credits.
Yeah.
On this same thing because of that issue.
Right. Yeah.
and how to take care of the population group and what to expect, because you know, and this is becoming more prevalent, and I think it's very
Very much
important for
so.
us to embrace this as clinicians and help move, you know, the culture and us further into what this could look like.
And the whole thing is taking care of these, you know, women in my
100%.
case or whatever.
Right.
It's, we need to know how to do that,
Right.
because they're still our patient.
Absolutely, 100%, 100%. So it talks about social and familial support, and it says high social costs or impossible for the LBQ women and TNB people to live openly and as authentic selves. They find that they are succumbed to family rejection, unfortunately. Yeah, community spiritual level at the same time. And it's harder, like religious or even cultural backgrounds. So, and remember what family means, right? And it just doesn't mean just, you know, your immediate family. Family could be the community. You know, that encompasses a different social aspect even. Education and economic stability. There are some interpersonal and institutionalized prejudice and legal protections that affect the economic stability of that gay, LBQ, and TNB people. While some still live in poverty, it says it corresponds with presence or absence of legal protections, unfortunately. So we need to understand this, and we need to know that it exists in other, you know, in other aspects of that. Legal protections, it talks about geographic location determines rights that change frequently. So there is unfortunately an anti-LGBT legislation which aims to overturn non-discrimination ordinances. There, you can look into what the state is, what state that you're going to be practicing in, and see what's happening in your state as far as legislation and what all's going on and the protection that this patient population group has. So look, legislation that affects protective employment relationships, adoptions. See, there it is, same-sex marriages. We know that that exists. It's legal in some states and not in the other, you know, and so maybe that's very important for us to understand as APPs and the population groups that we may encounter. Violence and harassments, of course, unfortunately, once again, high levels of harassment and assault can occur in public places. So you can see statistics surrounding that, intimate partner violence, which we're going to be talking about in a couple more lectures from now, and how that's underreported in this population group as well because of that fear of disclosure or actually coming out with that. And here we go, barriers to healthcare. So it's our responsibility as clinician to know that there are financial barriers in place, less likely to have insurance, more likely to have medical debt. There's historical trauma, emotional, psychologically wounding occurs over the lifespan. So we need to know that these things exist. And like Terry just said, there's lack of clinician knowledge, unfortunately, the understanding of the needs of these people and how can we help them as clinicians when they come into our office needing things from us. I know Terry has a story about that as well, getting referred.
Yeah, so of course I do a lot of postmenopausal hormone replacement, and patient requested to see me, going through sex change, transgender for the past few years, and didn't feel like that her hormones were balanced. And so she was referred from an area primary care office. So after reviewing the notes, and when I realized what it was that they were asking me to do, I am not the person for them. I don't have any background to help with the replacement. So this female needs to be referred for further, not further evaluation, but further treatment to a male to female endocrinologist that can help them with that male to female transition. Endocrinologist would be the person that they need to be seeing, somebody who is the expert of how much of the hormone that they need. You know, I talked with one of my doctors yesterday, and we may need to consider that training at some point. But right now, it's an endocrinologist that needs to.
So
be
think about it
handling
from a
that.
patient perspective, just like that. So the patient was referred from this one provider to Terry, right? Women's health provider, thinking that she could help this patient. Well, she's not the person for the job. So was that a lack of knowledge? So that could be a factor. So now the patient's like, okay, now where do I go?
Right.
You know what I mean? Because it's
So
not the
we're
fact.
making some phone calls, even though I can't
Right.
help this
Right.
patient for this in this particular office. We're making some phone calls to find out where she can go
Right.
to get the help she needs.
Right.
Yeah.
And so that is so important. And I think it's important that we have to look at all those factors and what can we do when a patient like that presents to us, and where can we refer them? What's the appropriate place
Yeah.
to
25
send
years
them?
ago, I had no clue that was going to be,
Right,
I was going to be
right.
faced with.
But you have a
that
doctor who,
particular-
to me, is embracing that and
Yeah.
saying, hey, you think maybe we should look
Yeah.
into providing care for this patient population group? Do you think there's a need within this community? And I think that's so important for us to embrace, like a potential,
Well, we get so busy in our day to day, and so that's something that we probably need to talk as. Would that be even something that would be feasible for us to do?
Right. Yeah, absolutely. So I love the fact that she's got a provider that's open to
Mhm.
maybe some other things. So
Yeah.
this is very, very unique, and I think that's great. So gender affirming care for transgender and non-binary individuals. There's some social interventions, like the use of names and pronouns aligned with that gender identity, legally changing names even, or gender, with documents, how they present. There's the hormone therapy changes, secondary sex characteristics to align with the gender identity to which they, just like that patient that says, I don't identify with these. I don't identify with these. This is not for me, and how can we get them where they want, or where they're wanting to be. There's that surgical procedure. This is your patient completely, how to fix what she doesn't identify with, and, improving her quality of life, her mental health, her self-esteem, to make her identify with the person that she feels like she mostly identifies with. And there's an insurance policy. So there's another hurdle to which this patient population group has to jump over, unfortunately, to get to where they need to be.
I've had some coverage though that they
Good.
Yeah, because I
Good.
see some lesbian couples that I'll see the one, and then I'll see the partner,
Wow.
and so I kind of know their situation, and then I've had some where they were covered by the other's insurance. So,
That's great.
Yeah,
So
we're
great.
beginning to see those changes.
So great. And I think that's so important. So there's that specific health concerns may be addressed during a visit or an exam and vary by race and sexual orientation. There's your mental health, body image, body composition. I think we've kind of went through some of that. Substance use, like bars and clubs offered safe spaces, so to speak. Cardiovascular health. That says TNB people have higher risk factors for cardiovascular disease. There's not much data that kind of speaks to that. Endocrine function. So it says in the past, it was believed that LBQ women have higher rates of endocrine disorders like PCOS. But
Disproven that.
there you go. Studies have disproven it. So see, that's what happens. And that's what Terry and I were kind of discussing collaboratively before we even went through this lecture about, how much data do we have on this patient population group? I would like to see further on down the road as this program progresses for us to maybe throw somebody into doing a project that surrounds this patient population group. Once there's some data out there that we can kind of pull from, that would be nice. So gender affirming hormone therapy is safe. Risk of bone density loss if therapy stops. And I know you and I had talked about hormone replacement therapy. And what was it that you were saying that about if we could do a research project
Research
would
on like, so women after years of exposure to estrogen, when would it be the same if they started out as a male after years? I was just curious.
Yeah,
and
exactly. I mean,
knowing
and
that bit of information.
yeah, and I bet you coming on down the road that that's going to be coming out,
Mhm.
believe it or not, to see if that does cause an increased risk.
Mhm.
The same, you
After
know,
the estrogen exposure after years of having it.
exactly. So vaginal and sexually transmitted diseases. It says sexual partners and sexual behaviors determine risk for contracting and transmitting STDs. We have to provide information as providers, of course.
Well, women, I'm in the same sex, but I want to tell you, they're still at risk for sexually transmitted infections. I find it out all the time. So don't think that they can't be if they're just not having.
Oh,
sex with us.
100%. 100. You have to let them know that there is that risk factor
Yes.
always. You know, I think she even talked about a patient that she had that actually was a swinger, so to speak. You know, so you may have patients who may kind of go different directions who are bisexual.
Yeah, and I appreciated her coming to tell me that, because that way I thought it was just between her and her heterosexual husband, and no, there was other involved.
Yeah.
So I needed to test her for STDs.
Right.
So
Right.
I wouldn't have known that through my assumptions unless you told me. So.
Right, exactly. So gynecological cancer, screen for cancer based on what organs the patient has, right? That makes sense. Breast cancers, I think we've really went into real big detail about breast cancer on the last lecture. But no studies have really truly determined whether TNB people are at higher risk. Like I said, there's not enough information out there. So it'll be nice to see what happens in the research that takes place. You know, we talk about this now, but it's going to be unique later on down the road to see where we go. There's cervical cancers, risk factors and predictive factors for cervical cancers are common in the LBQ women and transgender men.
So when it comes to the pelvic exam, and a lesbian, there's some that have had full intercourse with a man, and now they may just be in a lesbian relationship. But then there's other lesbians that's never had intercourse with a man. So I do have to use kid gloves, so to speak, whenever I'm doing my examination on them. And you know, I basically talk them through it and take my time with it, so that
absolutely
I'm not rushing them or forcing anything. So try to making them as comfortable as possible. So to do what I need to do to make sure they're healthy.
Right, I agree. So ovarian and endometrial cancer, once again, there's limited data available for us to kind of really jump into this, but there are risk factors, of course, and we kind of talked about this in the last lecture. So preconception and pregnancy experiences, parenthood is common for LBQ and TNB people. I actually, one of my favorite deliveries that I ever had as a nurse when I was a labor and delivery nurse was with a lesbian couple. And it was a great experience. And I will never forget that as long as I live. So, you know, embracing those opportunities that we have is so important. Becoming pregnant can be stressful and costly, you know, and I think those are conversations that we need to have with patients and their expectations and their needs or wants in their life, you know. So here's the youth. Additional challenges, of course, higher rates of substance abuse or use, tobacco use, early intercourse, multiple sexual partners, risky sexual behavior, negative reproductive outcomes are also common. There's a high risk of major depression, suicidal ideation, suicide attempts.
I see that too.
Yeah.
Sure do.
So we have to understand that patient population group as well. And then we swing to the older adults, those over the age of 50. These patients experience age or sex discrimination. They don't have as much social and familial support. High poverty rate, once again. Disabilities may be higher among the LBQ women and TNB people, and they may experience violence. So some of these things we need to understand when we're taking care of patients and being their providers. So many clinicians hesitate to discuss sexuality with people who have disabilities or even chronic illnesses. And I think we could probably say that about any person per se. You have to be able to have those difficult conversations, so to speak, and we have to understand that they exist so we can have those difficult conversations.
Well,
So-
they sometimes are embarrassed,
Yes,
but then they think that they're going to shock me, or that
you're going to
that
judge them.
I'm going to
Yep.
judge them, or I'm going to be embarrassed.
Yep.
And so it's sometimes you have to help them along to let you know to help them get across what's on their mind
Right.
and what they want to talk to
Right.
you about.
And I think like this last, and I'm thinking it's the last slide. The last sentence to me is a take home. And clinicians should provide same quality of care to all of their patients. So no matter who walks into your office, you're going to treat them like you would the next person.
I want them to know that. I want them to know that I'm going to take as good a care on them as I would somebody else.
100%.
That's any of them.
100%.
Anybody.
100%. All right, guys. So we're going to end this recording and we will catch back up in a second. Take care.